Today, Muliwanji and Sanda Malawi. My name is Natasha Adodo, all protocol observed. I am the Communications and Engagement Officer here at the Scotland-Malawi Partnership. Just a few housekeeping rules, not rules, but notes for today. We have no fire drills planned at the moment. So if there is a fire, or in case of a fire, the exit doors are just right outside. We have our camera right here. We have a device called the OWL. So every time you speak, the device will trace your face and your voice. The toilets are just right outside the store right here near the coffee and tea section, just to your right. And we also do have Wi-Fi today. So the Wi-Fi code is right over there by the door. And the Wi-Fi would be council public Wi-Fi. And for everyone else online at the moment, the meeting is being recorded today and it will be put up on our events page on the Scotland-Malawi Partnership website. Feel free to introduce yourself as well in the chat box. And if possible, when you are speaking in the Q&A section or during your presentations, please do switch on your camera. And you're all allowed to live tweet during this meeting today. Right at the end of the meeting, we'll have a survey. It's only 3 questions, so please do fill in the survey for us. Right after the meeting, we also have some tea and coffees outside, so you're welcome to stay right afterwards and just catch up with a few of our colleagues as well. I'll now hand over the meeting to our chairperson of today, Heather Kubi.
Good morning, everyone, both here in the room and online. Welcome particularly to our student presenters here from Maldent, to colleagues everywhere, all of you who are attending, and our friends. My own connections with Malawi. Oops. Can you hear me? Yes. My own connections with Malawi are also in the health field. And so I'm a regular attender, either online or in person, at the health forums. And for the last 11 years, we've been building a cervical cancer prevention program involving both screening and same-day treatment. So another public health initiative. And indeed, prevention is surely the way forward in many areas of healthcare in Malawi. We're lucky to have spread in the last few years to 8 hubs and 42 health centres across all regions of Malawi. So in terms of sustainability, it is necessary to think of how that expansion happens. I and my co-lead, Dr. Christine Campbell of the University of Edinburgh, have visited Malawi so many times, and every visit brings new joys, new friends, new contacts. So I'm thrilled to be able to spend some time today discussing another area of prevention and health improvement. Oral health is relevant for all. And with both the Scots here in the hall and Malawians and all of you online, it's relevant for everyone. What inspires me most is to meet with those already involved or about to be involved in dignified partnerships with colleagues and friends in Malawi. And that's really all I want to say as an introduction, why I'm here, why I am chairing this, except I didn't tell you my name, which is on your agenda. Heather Kubi, I'm chair of the Scotland-Malawi Partnership. And it gives me very great pleasure to introduce our first speakers who are online, who are going to give a talk about the Maldent project. Dr. Peter Chimimba and Dr. Mpatsa Mipando should be online, and I hope we can connect now to the Kamuzu University of Health Sciences, KUHES as we know it.
Hello, I'm Mpatsa. I'm not sure whether you're able to see our presentation.
Yes. We can, Mphatso.
Okay.
Thank you.
So,
Please go ahead.
okay, thank you very much. From my side, it's paused. So my apologies, the technology. Anyway, I'm presenting together with Peter Chimimba, who's the coordinator, day-to-day coordinator for the Marden project. I hope you are still able to see it.
Yes, we can.
Yes.
Okay. Okay, thank you very much. Jeremy Bag, who is also there, I think in attendance. We just want to give you an overview of our project, which in essence, it's come to an end, but we'll discuss that. And from the beginning, we just wanted to say it's been a great journey, a partnership, as you will see in what we have. I have problems on my side. It's not moving. Okay. Thank you very much. So this is just to give you why the oral health. If you look in Malawi, currently our population is about 21 million, and we currently have around 40 dentists. If you compare to UK, where you had 35,000 dentists in 2018, and the recommended ratios and what we have, you can imagine 40. And even of these 40, I think only 4 are in the public sector. The others are in private. So if you go to the districts, you wouldn't have a dentist. Rather, we are supported by the EBERE trained dental therapists. So we really had to think of having dental surgeons in Malawi because it is a requirement and it's a need. This is just to give you where it all started, and we are thankful to the Royal College of Physicians and Surgeons. I had visited the University of Glasgow, and I met then the head of the dental school. And with the support of the Royal College, we invited him to come to Malawi so that he can understand what we were discussing, because a dentist in the UK might be different in terms of the expectation and also where they are working. So he had visited Malawi. I had to show him Kamuzu Central Hospital and later on the Queen Elizabeth to see where we are practicing. And by chance, we had also a Scottish government official, Ian, who's since retired, and we had a small chat. And from there, we were able to put in a grant, and they supported us with 60,000 pounds. And it's through that we were able later on to visit with a team to Glasgow. And through that, we were able to put in a grant that was able to help us to start up the project, which we call the Malawi Dental School Project. And I'm happy to say that in 2018, by the visiting Ben McPherson, the member of Scottish Parliament, we were able to be told, and the official announcement was made. And here he has visited College of Medicine. And with me here are my friends now. On the far left, we have Jeremy Bag. I think he still had hair at that time, and Peter Chimimba, who was part of our team, and myself. And this was a momentous occasion because the announcement of the funding that we got for the dental school project. Basically, what we wanted, 2 things: to establish an undergraduate dental school project, and with emphasis that we wanted to produce graduates that were globally competent, but locally relevant. And also to help the Ministry of Health to set up the National Oral Health, because we didn't have a strategy in terms of a policy and others. And we realized that it wouldn't be the colleges, but it would be the ministry. So we were supporting the ministry to set up that National Oral Health policy. So over the years, we've been able to raise funds to the tune of 1.6 million towards the 6 years of the Marden project, with the objectives to, as indicated already, to set up the BDS, develop a national oral health policy, and also requirement of having a purpose-built infrastructure, because we don't have an infrastructure to host this dental school, and also to conduct a national child oral health survey and establish a dental caries prevention program. Now, have we achieved that? For us to know whether we have achieved it, I would want to bring in Peter Chimimba, who will take us through on what we have done over the past 6 years. Peter, over to you.
Thank you, Mwapatsa. Indeed, one of our first objectives was to establish a BDS program at that time, College of Medicine, which is now part of Coolhurst. We worked tirelessly, actually, to produce a curriculum. And those of you in academics will see and be aware of how difficult it is to establish a curriculum. The University of Malawi were very particular, but we were all prepared for all the work that we had to put in. And the curriculum took us almost a year, but it was approved on the 21st of March, 2019 by the Senate. And here I need to just say we were very pleased with the support that we got from the Glasgow University, from University of North Carolina, and University of Witwatersrand, and all the staff from COM were involved. Here you see two pictures, one on the left, the famous Professor Bagg in a lighter suit, and next to him, Dr. Mukiwa and myself. And in the middle is Mwapatsa, who was the principal at the time. And towards the end there is James on the left, who is now the acting head of department training dentist. And on the right, I'll be very brief here just to show you the first cohort that we have of 10. Thank you, Mwapatsa. What we have here is the role that University of Glasgow played in bringing together the flying faculty, and the visits, in fact, were very instrumental in producing the work that we're so proud of at the moment. One of our main constraints is lack of teaching staff, but this was ably filled in by the flying faculty. This started right from the beginning. The time we got the dental students in, they were there to help us through. And one of the things that we were very keen to do was to set up a national oral health policy. The minister made it very clear that one of the problems they had with access to oral health was that there wasn't a policy framework. And we too at the university were keen to make sure that our students, once they qualify, they came to a program that was already there in place. I'm aware that Winston, if he's here, he'll be talking more about the National Oral Health Policy, but the 7 pillars that are there, as we can all see, the leadership and governance, and we looked at dental public health, clinical practice and patient access, human resources for oral health, infrastructure and equipment, oral health financing. And one of the things that the minister was keen on was on data, prevention, and also on the management. So that has been done. And one of the objectives was to establish a national child oral health program, improvement program. But as you all know, you cannot have a program, especially if you're dealing with the concept of child health, without having a survey as a baseline data. And this survey was done and presented in October 2023. And we also had a meeting. But here you see the results. Again, I know that Lorna is there and will present this in much more detail. But we looked at 6 and 12-year-olds, or totaling almost 3,000 children. And the overall prevalence for 6-year-olds of dental caries was 47%. And one of the things that was interesting was that the figure in the north was quite high, but that will come clear as we go along within the next few minutes. One of the things that Jeremy appreciated was basically that the facilities, both at QE and KCH, were not really fit for purpose. So we had help from DentAid, from the NHS, the Greater Glasgow area, and also from the Royal College of Physicians and Surgeons and Henry Schyan, who we've continued to work with up till now. and they helped us to do a number of things, improve the dental facility at KCH, and also to establish an area for preclinical training and simulators, as you can see on the right-hand side. On the left is before, and then on the right is after. Thank you. And the building design workshop, Mapatsa, would you like to take on from here?
Okay, just to say that as you indicated on the objectives, we had said we needed a purpose-built infrastructure. So we were helped with a professor from the Glasgow School of Art who came and they carried out what we called as the design workshop. Just to stress that it wasn't only for the College of Medicine, but we were able to invite members of staff and students from then the Polytechnic, now Malawi University of Business and Science and Technology, where they were involved. And we brought in members of staff and designing what we wanted for the new dental school. And this is just the final stages being done by John McCaslin and colleagues from a consortium with Malawians. And we are happy to say that because of the MADENT, we were able to convince partly the the World Bank to support the College of Medicine, now KUHES, with funds where 5.3 million has been secured to build the purpose-built infrastructure that will host the dental school. And if all goes well, we are hoping that by November, December, construction will start. And this is part of the teaching infrastructure that will be there. The other thing that MADENT, though it has finished, is that we realize that the graduates need to, and the dentists that will produce, they will need a platform where they can practice. But also when you go to the health centers, you don't have a place where they can purposely learn. And what we are showing here, hopefully, Jeremy will talk about it, but working with Ameka and the others, they are coming up with a design and a facility in Chiromoni that will be an exemplar of what every district, every health center might have in terms of oral health. And this is just a design, and we are thankful for the work that is being done because for us, our students will have somewhere where they can go to practice. So what's the next step? We want to make sure that there is continuous support on the BDS. As Peter has said, we still have a few faculty. We are some that are in training, so we'll continue having the flying faculty. We want to make sure that the policy that was developed is implemented, not just produced as a paper. And we also want to make sure that there are improvement programs. So working together with WASH and nutrition, and I know Tracy and Jeremy will talk more about that. And we want to make sure that there are functional surgeries in districts and health centers, and that's what I've just talked about, the pilot project. Lastly, let me say that we have been successful because of the different partners that are here. I won't go into the details, but the regulatory, they are academic, they are government, all of that, making sure that the project is successful. If you would want to follow more, there is a blog that is currently running, and you can get the details there. And just to say Zikomo, and thank you very much for listening. Thank you.
Thank you so much, Mpando and Peter. It's chilling to think of the number of dentists that you have and have had in Malawi. But it's thrilling to see how far you've advanced in 5 to 6 years, making use of all the networking opportunities to include partners, whether they're academic, on the ground, charitable, and commercial companies. It's an exemplar, therefore, of how we should work together. Thank you so much. And every good wish for the future in the development of the next stages. Now, I'm sure that as people have been listening, their mouths will almost have been agape at that progress that's been made. You may want to put comments or questions into the chat box. There will be question and answer session at the end and time for discussion. So if you're online, put them in the chat box. Otherwise, build them up, make a note of them here in the room for later. But for now, we'll go on to our next presentation, which expands on the project itself by describing what has been achieved. And I hope that we have online Dr. James Mchenga, who is responsible, I understand, for delivering the curriculum, and our two dental students from that first cohort, Esther Komba and Jifunda Banda. So, Dr. Mchenga, are you there?
Fortunately, I'm not seeing him.
Okay.
He was there
Yes.
before, but we lost him.
He's available. I think he'll take on because you're ready to go. My lap. Sorry, Chair, this is Peter.
He's
Yes.
he's here now in the room. He's still just maybe
Yeah.
disconnected.
Okay.
I was in two places.
Ah.
Whoops.
Hello.
There he is.
Can you hear me?
Yeah, yes, we can hear you. Oops.
Ah,
There we go.
Oh,
thank you.
that's wonderful.
All right.
Mchenga,
Am
please
I
go
good to
ahead.
go?
Yes.
All right. Thank you.
And come up now, or I don't know what you.
Okay. So let me share my screen, and I'm looking for this one here.
Yes.
And thank you so much for the opportunity. My name is James, and currently I'm the acting head of Department of Department of Oral Health Sciences at KUHES. So the launch of the BDS degree program on August 22, 2019, actually ushered in a dream that came true for the university as well as for the country. It was a giant step, as far as I'm concerned, in towards the development of an oral health care workforce at the graduate level in this beautiful country of ours. Currently, starting with those students that started, we have them in BDS 5 now. As you can see from the figures, 10 of them. The next classes are just as indicated. So at the moment, we have just about 40% females to the 60% males that we have as a number in 114. And what I would like to say is that this BDS 5 class, in the first semester, we have a clinical record here of what they have done. And you can see that they have done up to 97 consultations and treatments that have been rendered to students, to patients. And that if we put a mark of 60, or rather the procedures numbered 60, you see that in fact, 90% of the students achieve that, except for one student who is lagging behind. But we have identified his problems, and we will sort him out in this second semester. So this was only for first semester, and we are sure that this will be more than doubled, if not at least 1.5 times these figures in the second semester. So much so that by the end of next year, when they graduate, we are definitely hoping for a 10 out of 10, literally. And of course, you have the list, and here they are once again with Dr. Chimimba as well as Dr. Mulotana Mariga. But one of the things that I'd like to talk about is the impact that the dentistry has at KUHES has at Queen Elizabeth Central Hospital. Because of the introduction of this dentistry degree program, we have managed to make sure that the ENT surgery, general surgery, head and neck surgeons, internal medicine, neurosurgery, oncology, ophthalmology, and all these surgical disciplines, there is now a very beautiful link with the oral and maxillofacial surgery. And therefore, this is one of the outcomes
of the Malden project. Probably an indirect one, but yes, an outcome all the same. Currently, our local staff situation is what's on the left-hand side there, which is not very good in terms of numbers. But this is supported by the flying faculty, as we have heard, and probably we'll listen to some more. And so for the future, I think that the situation needs to be improved, where we have specialists in the various areas of subjects, I mean, the various disciplines of dentistry. And so this would be the way to go as far as the future is concerned, because unless we have done this capacity building, then the school may not fare as much as we would like. So this is one thing that probably this next phase can be talked about. Another offshoot of the dental school, I heard Professor Mipando talk about the collaboration amongst various stakeholders. And one of the offshoots, this was not intended to, right from the beginning, is that there has been the smiling surgeons of the USA who have come in and have donated equipment and instruments for maxillofacial and oral surgery. And they've had 2 camps so far, and up to 50 patients have been operated over the past 2 years. And then they have sent us a mobile dental clinic. In fact, this is on the road. That bus that you see over there has been sent in order to have mobile dental clinic so that we can go to the rural areas. I'm sure that most of us would remember that one of the things that sparked the school, to start the school, was the traditional dentist. There was a video that was shown on Zodiac TV about the traditional dentist who was doing improper dental treatment. But this bus is one of the answers to that kind of thing. But apart from that, another offshoot is the fact that the smiling surgeons and with their partners in the US are sending 27 containers to all hospitals in Malawi of medical equipment and consumables and so on. 6 of these are already on the way. And so this is one of the offshoots of the development of the dental school from Malden. And of course, the smiling surgeons haven't stopped there. But the 5th thing that they have done is that a student, at least as of now, one student has got a full sponsorship to study dentistry until he finishes. So this is one of the side effects of that. So we can say that on the local ground here, the excitement is in the air. And we think that once we have developed from this way, we need to move from being a department to actually a school of our own in terms of oral health sciences. And I think that the nation is actually ready and waiting for that transition to be a school of oral health sciences and offer those services. Thank you so much for the opportunity. Over.
Okay, greetings everyone, both in Malawi and here. My name is Chipundo Banda, a BDS Year 5 student at the Kamuzu University of Health Sciences in Malawi. I am the current president for the Dental Surgery Students Association at the university. My home village is Lilongwe, which is the capital of Malawi. So initially, I was pursuing a degree in the biological sciences at the University of Malawi, and I applied for a transfer to do medicine at the then College of Medicine, which is now the Kamuzu University of Health Sciences. And I was offered a place. So at the same time, dentistry was just introduced at the university, and I also applied. And I was also offered a place. So in the end, I had to choose dentistry. Being the first ever Malawian dental student, it was both exciting and challenging at the same time. It was exciting since it meant lots of opportunities ahead of us, and challenging since we didn't know what to expect, what the next step would be like. I enjoy being a dental student since I have adequate time for my studies, and also I am able to do my personal things. The most difficult part of this journey has been having inadequate number of staff and inadequate materials for our clinical training. I'm grateful for the flying faculty members who are always there for help in this regard. I am also grateful for the Hope Foundation through the Royal College of Physicians and Surgeons of Glasgow for making this journey here to the UK a success. It is indeed a rare opportunity. So my future plans are to become an academician once I finish my studies, and this will help me to nurture the future generation of Malawian trained dentists. I also look forward to do specialist training when opportunities arise. So I am interested in the dental public health, orthodontics, and oral pathology. I can't wait to join the healthcare workforce to help my people. Thank you.
Good morning. Good morning, everyone. I won't say much because he's already said a lot as our president as well, so I think it's the same. My name is Esther Komba. I'm a final year student as well, studying Bachelor of Dental Surgery at the Kamuzu University of Health Sciences in Malawi. I also come from Lilongwe, Malawi, which is the capital city, as he already said. I started my higher education as a physiotherapy student, but ended up on what has been an exciting journey of the BDS program because of my first-hand experience in not being able to access the standard care or healthcare when needed whilst I was growing up. As such, becoming a part of the change makers in this field was something I didn't have to think twice on when the program was first introduced, despite having already begun my training in physiotherapy. Dentistry has taught me problem-solving skills, teamwork, and leadership, among other things. And more so, being a part of the first cohort has taught me to adapt quickly to new developments. All of these aspects have helped me in other areas of my life, such as relationships, be it work or friendships. The biggest challenge, as he already put it, as students, we have been met with struggling for resources and dental materials in order to deliver standard care to our patients, whilst meeting our clinical requirements as students. After I qualify, I intend to specialize in restorative dentistry, whilst being a part of the academic faculty, so as to grow the profession and overcome the challenges I met as a child seeking oral health care in Malawi. Thank you for listening.
Thank you so much, Dr. Machenga, for your update on what is happening in the School of Oral Health. The interactions you were describing with your clinical colleagues in Queen Elizabeth Hospital are a really important offshoot, and mobile services, or at least some kind of distribution through the country, is obviously a goal that will expand as your ability and funding allows. Congratulations to two amazing change makers. I think that the future in Malawi for dentists such as you two is assured, because you will put a lot more back in than you have received out. And that is a wonderful thing for a country to progress to. Thank you all. Again, questions for all three of them, please put in the chat box. But at the moment, we'll go on to hear a little bit more about Malawi's national oral health policy. So again, this is an online presentation from Dr. Wiston Mukiwa, who is Secretary of the Dental Association of Malawi. Dr. Mukiwa, are you there?
Yes, I am.
You are.
Good morning.
Good morning. Please do go ahead. Thank you.
Thank you. Let me try sharing. Can you see my presentation?
Not yet.
Not yet. But I've shared it. Let's see what is happening.
There it comes. Well, there comes Zoom.
Can you see it?
We're just seeing your Zoom browser.
Oh. Let me take that off.
There we go.
Now we can see it.
Yes, thank you.
Thank you very much. Sorry about that. My presentation is a summary.
Sorry, if possible to put it in presenter mode, then we'd be able to see the slides a bit better, I think. There we go. Sorry, yeah, the slideshow mode.
Can you see it? Hello?
Yeah, it is now smaller. Can you do slideshow? Oh, presenter, sorry, presenter mode.
I am in presenter mode.
Yeah.
Yeah, it's just we're seeing the same screen as the shared screen.
It goes to display settings.
Are you able to see?
I also have it. Let me see if I can have any better success here. Is that his or mine?
Really? Yes.
I think this is mine. Oh, wait. Am I just confusing things now? Oh, mine's gone to that too.
Presenter mode.
Yeah. Dr. Mukiwa, I think we should just go with what we've got.
Okay.
We can see enough. Thank you.
You can see enough from...
Yes.
So if I carry on, is that all right?
Yeah.
Yes.
Okay. In the 10 minutes that have been given, I will just go through a summary of the National Oral Health Policy for Malawi. In presenting, I can't disassociate my feelings, personal feelings, from the presentation, because for me, this is a culmination of a very, very long journey to get to this point. As has been alluded before, oral health personnel in the country has always been a problem, and we did not have a school of our own. But when the school was established in, the program was, BDS program was established in 2019, the possibility of having a national oral health policy sorted out was a big, big bonus for us. I hope you can hear me.
Yes. Yeah.
Good. Now, the aim of the National Oral Health Policy is to provide a policy direction and comprehensive framework for effective implementation of oral health interventions at all levels, and contributes towards improving the oral health of Malawians. For the last, almost since the 70s, we have sort of trudged on without proper framework. We have tried a combination of training various cadres to answer to the shortage of oral health personnel, but all that was going on without a proper framework. So this is a very good, welcome development to have a proper framework that can guide us. And the key challenges that the National Oral Health Plan addresses are oral health leadership and governance. Even as we speak now, the oral health is not really presented at decision level, at ministry level, and we would like to see that. We have now started training our own dentists. We have to look at the dental team and the leadership challenges that are there within that dental team. Limited awareness on prevention and management of oral and dental health infections. Inadequate human resources for oral and dental health services. Insufficient guidelines and protocols for oral health and dental services. Poor specialized infrastructure and equipment in the facilities, especially in our health centers and district hospitals. Inadequate funding. Weak collaboration and partnerships among relevant stakeholders, and promotion of evidence generation for informed decision making. As Peter was saying, data, data, data. In going through this, we looked at the most important documents that are there so that we're in line with the Constitution, the Malawi Growth Development Strategy 3, the Health Sector Strategic Plan 2, 2017 to 2022, and Malawi Vision 2023. And we looked at the relevant legislation that affected us, the Public Health Act, Local Government Act, Medical and Dental Practitioners Act, Nurses and Midwives Act, Pharmacy and Medicines Regulations Authority Act, HIV/AIDS Prevention and Management Act, Public-Private Partnership Act. All these were relevant to us, and we had to make sure we are in line with the aspirations of all those. And this slide shows the other policies: the National HIV and AIDS Policy, Decentralization Policy, National Education Policy, National Health Policy 2018 to 2030, Nurses and Midwives Policy 2018, and other international instruments, especially Sustainable Development Goals, the WHO Resolution of 2021, this series on oral health that appeared in the last set, and the WHO 2016 Manual on promoting oral health in Africa, prevention and control of oral diseases and NOMA as part of essential non-communicable disease interventions, and the Minamata Convention on Mercury. The policy identified 7 pillars: leadership and governance, dental public health, clinical practice and patient access, human resources for oral health financing, infrastructure and equipment, research and data information management. And these we pulled out as the most important 7 pillars that the National Oral Health Policy would address. In leadership and governance, the policy statement was that rural government would be to ensure the promotion of mechanisms for effective leadership and governance for oral and dental health services. And as an example of strategies that would follow would be ensuring a conducive environment to effective collaboration, coordination, and oversight of oral and dental health services, to develop a clear scope of practice for all cadres and oral and dental health care workers, and to develop a resource mobilization strategy for improving oral health services. In terms of public health, government shall ensure effective implementation of interventions aimed at enhancing public awareness, prevention, surveillance, and control of oral and dental diseases. In this, the strategies will include developing a national preventive strategy for enhancement of oral health, integrate oral health care into the NCD agenda to address key risk factors for oral diseases and strengthening surveillance activities for early detection, prompt treatment, and reporting on oral and dental health problems. In clinical dental practice and patient access, the role of the government would be to ensure that quality and adequate oral and dental health services are accessible at all levels of care to all Malawians. And the strategies in here would include promoting access and equitable care of patients with dental pain in line with the Essential Health Package and the WHO Basic Package of Oral Health Care, ensuring reliable supply chains of appropriate drugs like local anesthetic and consumable materials to support delivery of oral and dental care, and promoting use of mercury-free materials for dental restorations. Human resources for oral health, government would ensure the availability of adequate professional staff and upskilled oral health care workers of all cadres at public, CHAM, private facilities, and in the communities. Strategies include ensuring adequate recruitment and equitable deployment of oral and dental health workers to the various public, CHAM, and private facilities, promote periodic visit of oral health cadre establishment and regular workforce planning, support for continuous professional development, CPD, for oral health professionals at all levels. Pillar 5 was oral health financing. Government would ensure an enabling environment for resource mobilization and adequate financing of both preventive and curative oral health services at all levels of the healthcare system. Strategies in here would include developing an oral health services resource mobilization strategy, promoting comprehensive planning and budgeting for all health services in public and private institutions and other stakeholders, and introducing a specific oral health budget line within the national budget framework at national, central, and district hospital levels. Infrastructure and equipment. Government's role is to ensure the availability of adequate and quality infrastructure and equipment for the delivery of oral and dental health services at all levels of care. Strategies include upgrading rural and community hospitals and some health centers to provide emergency oral health care. Ensure inclusion of oral and dental health infrastructure and equipment needs in the capital investment plan for health, and promoting the development and implementation of facility-based equipment maintenance plans. In Pillar 7, research, data, and information management, government would ensure the promotion of mechanisms for enhancing data generation, information management, and research for oral and dental health research. Strategies would include enhancing the completeness, timeliness, and the quality of oral health data collection during routine treatment, ensuring the expansion of oral health indicators coverage and comprehensive reporting of oral health conditions in the DHIS2, promoting documentation, translation, and utilization of oral and dental health research findings, and promoting periodic national and oral health dental oral health service. Those are the 7 pillars. I've gone through them very quickly and would like at this point to thank all those that worked tirelessly to realize this dream of having a national oral health policy for Malawi. As has been said earlier, there were many, many partners. Task force membership was from the Ministry of Health, Ministry of Education, Science and Technology, Office of the President Cabinet, Medical Council of Malawi, Dental Association of Malawi, Nurses and Midwives Council of Malawi, Kamuzu University of Health Sciences, WHO, and University of Glasgow. And to all these, and to all the organizations that have made the dream of having a dental school in Malawi and producing the first national oral health plan policy, we say thank you. Thank you for listening. Hello? I lost them.
Thank you very much, Dr. Makiwa. It has indeed been a long journey for you, but what an exciting stage to have reached. That framework, your policy, your 7 pillars, they are similar, of course, to the policies required in other areas of public health, and I recognise many of them. One of the ones that stood out for me was your reference to inclusion within NCD, something that we ourselves in our cervical screening work have found problematic as well. So good luck within that. Many aspirational points within your strategies, and I'm sure that people will have a number of questions about that. But getting that budget line in the next documentation from the ministry is probably the most crucial for success and progress and sustainability. Thank you very much indeed. Now we're going to talk a little bit more about the future by handing over to Dr. Don Chiweya and Professor Lorna McPherson, who are going to talk about towards a national child oral health improvement programme for the whole of Malawi. And Lorna, are you first? You're going to go first, please. Yes, look forward to hearing this. Thank you. Okay.
Thanks very much, and good morning, everyone, and thanks for the opportunity to speak at this partnership forum about our plans for a child oral health improvement programme. So we've just heard from Winston about the National Oral Health Policy for Malawi, and during its development, it was recognised that prevention and health promotion would really be the key drivers for improving the oral health of the population. And we decided the initial priority for health promotion really had to be children, because it's known that health improvement and the adoption of positive behaviours during childhood can have an impact right across the whole life course. So now, before my retirement from the University of Glasgow, my specialty was dental public health. And for over 15 years, I've been one of the national directors of a child oral health improvement in Scotland programme, which is called Child Smile. Some of you may have heard of that. Now, if we go back to the early 2000s, at that time, we'd seen absolutely no improvement in the levels of decay in 5-year-old children for well over a decade. And as they were starting school, well over half of them already had decay in their teeth. And that was despite the fact that we're regularly going into schools and giving the traditional oral health education approach in nurseries and in schools, but nothing was happening. So we realised we had to really change the approach we were using. Instead of simply just giving information and expecting it to result in behaviour change, we realised we had to try and enable this to actually happen. So we started to develop an intervention, which was very much based on public health principles. And we feel that these principles would really be appropriate to work with in Malawi as we try and develop a child oral health policy in Malawi. So the principles we've been following in Scotland include, first of all, having good data. We've heard about data all the time. So we have good data in Scotland in regard to child oral health. And this is so we know the extent of the problem. Then the next thing we did for Child Smile is you conduct a review of the literature to find out actually what works for improving child oral health. This is obviously going to be very context specific. So you have to really do a situation analysis for a particular country or a particular area, so we understand about the infrastructure, we heard about finance, level of finances that would be available, and also speak to parents, speak to health professionals to actually see what is feasible in different countries. And then once these stages were all completed, we get everybody together, including stakeholders, ministries are very important, other stakeholders, to actually put together an intervention and then start testing it before it be rolled out. Now, over the past few years, with funding from the Maldent Project and the Borrow Foundation, there's been excellent collaboration between Scotland and Malawi to start to follow these principles to inform the development of a child oral health improvement plan in Malawi. So as we heard from Peter earlier, last year we had our first national child oral health survey, which was carried out in Malawi. And this was a great example of what close collaboration between the teams in Malawi and in Scotland can achieve. And we saw this at the planning stage and at the training stages, and then while the survey was actually happening on the ground in the 3 regions in Malawi. So the dental examinations were carried out mainly by trained dental therapists in the 3 regions, but there was also input from some of the UK team, including those from Malawi. Now, while these survey plans were underway, we did a global review of child oral health improvement initiatives. And in addition to that, the MALDENT project was able to provide small bursaries to 7 MPH students from KUHIS, so they could undertake on the ground the situation analysis in Malawi itself. So they did work in schools, they did work in primary care services, they spoke to a number of parents, and they looked at oral health and child oral health could fit into the NCD agenda, and also the availability of data, which there's quite scarce at that time, particularly for child oral health data. And Jeremy and I had the opportunity of providing a bit of support and advice to these MPH students in Malawi. And then in May of this year, we held a workshop in Penella, where the results of all this work was presented to a multi-agency group of stakeholders, including again from the ministries. And this led to discussions on what could be appropriate child oral health improvement initiatives for Malawi. So at this stage, I'd now like to introduce Dr. Don Chuea, who is a junior academic at KUHIS Dental School, and he's currently undertaking dental public health specialist training in South Africa. And really, I'd say over the last few years, it's been really great to get the opportunity to meet Don when I've been in Malawi, and from time to time, been able to provide some advice and mentorship for Don. And as part of his studies, Don will be joining the task force in Malawi to develop this child oral health improvement plan. And I have to say, I think it's great that into the future, there'll be a dental public health specialist actually available in Malawi who can have a major role to play in the development and implementation of national oral health policy within the country. So Don, over to you.
Thank you, Prof. McPherson. Good morning to you all. As you have heard, my name is Don. I'm one of the pioneer academic staff for KUHIS Dental School. Currently, I'm in my 2nd academic year of my registrarship in dental public health at the University of Pretoria in South Africa. As we have just heard, delegates met just outside Lilongwe in May of this year to discuss the development of a national child oral health improvement plan. Unfortunately, due to my study commitments, I was not able to attend. However, I was sent all the materials and have been involved in ongoing discussions since then. By all accounts, the meeting was very successful, with preparation for the workshop and presentation on day 1 being shared between Malawian and Scottish delegates. The scene was set early on, with the results of the survey being presented. The results showed that almost half of the 6-year-olds and a quarter of the 12-year-olds had decayed teeth. The lack of availability of treatment services was demonstrated by the fact that no fillings were seen among the 3,000 or so children that were examined. There was also important contributions on day 1 from the Ministry of Education around school health policy, the World Health Organization Regional Office of Africa about the Global Oral Health Agenda, and delegates heard about a new World Health Organization and UNICEF initiative, which is being piloted in Malawi to promote child and adolescent care visits. This provides a great opportunity for oral health to be incorporated into general health surveillance package, and the potential for a joint working potential for joint working in the area has already been explored further by the University of Glasgow team and the program lead post-meeting. Another area where a joint approach should be feasible is through working with WaterAid Malawi. The local representative gave an excellent presentation on the work of the charity in primary schools and early childhood centers. We are very keen to investigate the possibility of working with WaterAid to join up hand washing, nutrition, and tooth brushing in some small-scale feasibility programs in schools. On the second day, delegates used the information from day one to discuss possible child oral health improvement initiatives and potential barriers and facilitators to the implementation. The input of staff from the Ministries of Education and Health was very beneficial. Some of the major issues identified were lack of training, treatment services, and affordable fluoridated toothpaste. The need to work within existing health promoting structures and programs in schools and early childhood centers was emphasized. The chief education officer in the Malawi's Ministry of Education spoke at the end of the workshop and stated that the objective evidence presented via the survey results on the burden of dental disease in children was very powerful and important for influencing policymakers. A way forward was outlined, engaging the relevant ministries and the setting up of a child oral health task force, which could feed into relevant cross-cutting school health groups at government level. At present, a concept paper and terms of reference for the child oral health task force has been reviewed. Now, as a student, one of the requirements of my studies is to be practically involved in oral health programs that have a national impact, so that I learn how national projects are planned and successfully implemented. So this task force presents an ideal platform for my learning because of one, there are several oral health projects that are being planned, and two, the task force is made up of experienced local and international health experts. Therefore, there is no better space for my learning than this. I am very excited and looking forward to working on the multi-agency group, which will have representation from both Malawi and Scotland. Thank you very much for listening.
Thank you very much, both Professor McPherson and Dr. Chiweya. Obviously, for public health to work, we have to deal with the children first. And starting as young as possible is really important. Again, I'm sure there will be questions. Hope you're all putting things either into the chat or have them ready for later. We're running a little bit behind, but we do need to have time for that. So let's turn now to a new collaboration, oral health and the WASH agenda. And we've got a trio of speakers, Jeremy and Tracy, who are here in the room, and Maria Soko, who is with WaterAid in Malawi. Who's going first? Jeremy? Okay, right. Okay.
Thanks very much.
Invented different things on I've got big monkey.
Well, good morning, everybody, and thanks again for attending this symposium. As just mentioned by Lorna and Don, any efforts to improve oral health in a country need to recognise the large number of stakeholders involved. Dentistry suffered from being in a silo for decades. So a multi-sectoral approach is really important. And the two most common oral diseases, dental caries and periodontal disease, are both essentially preventable. And maintenance of good oral hygiene is key to any strategy that's trying to prevent these diseases. And the analogy with the WASH agenda and hand hygiene is immediately obvious. So in Malawi, challenges to both of those agendas include access to suitable facilities, availability of water, and an affordable supply of the relevant cleaning agent, be it soap or toothpaste. The very successful Scottish Child Smile programme that was talked about by Lorna is backed by years of epidemiological data, and it's become very clear that the major ingredient of the programme that brings success is regular brushing with fluoridated toothpaste. One of the issues that the Child Oral Health Improvement Task Force that Don mentioned is going to need to address is the feasibility of designing a supervised toothbrushing programme for Malawian schools appropriate to the facilities that are available. And one of the major challenges highlighted in the workshop at Pamela in May was the high cost of fluoridated toothpaste in Malawi. So following an introduction by my good friend, Professor Tracy Morse at Strathclyde University, we're now working with some of her colleagues in pharmacy to examine the feasibility of establishing a manufacturing process for what we're calling a no-frills fluoride toothpaste, so no red and blue stripes or anything like that, but it carries the fluoride and it cleans the teeth, which is the important thing. And if we could do that, it could enhance the affordability of a supervised toothbrushing program in schools. We've also got appropriate partners in Malawi in academic pharmacy and also linked through MUST with potential industrial spin-outs. Now, I mentioned earlier that oral health improvement programs need to be multi-sectoral, and our ambition to develop a supervised toothbrushing program in schools is one that we would like to pursue in conjunction with colleagues working in the wash sector and potentially in nutrition. There are examples already of such collaboration in other parts of the world, for example, the Fit for School program in Asia. Those working in the wash and nutrition fields in Malawi, like Tracy, have extensive experience of working in their schools, and as relative newcomers, we have a lot to learn. Through contacts I made via the Scotland-Malawi partnership with Elizabeth McKernan and Natasha Mwenda of WaterAid, we invited Maria Socko, a hygiene behaviour change specialist at WaterAid in Malawi, to join us at that recent child oral health workshop in Penella. Maria's input, which was based on her extensive experience in schools, was really, really valuable. And I'm delighted that she's able to join us today online on this oral health forum to share her views on the potential for integration between the oral health and wash agendas in Malawian schools. So, Maria, I'll hand over to you.
You're muted, Maria. There we go.
Hi. Sorry, I was speaking while muted. Thanks so much, Professor Bag, for that introduction. So yeah, I will just, it's a brief narrative on the potential integration with WASH, with oral health. So I just want to share with you what our views are on the potential integration between WASH and oral health. Like as WaterAid, we target schools and early childhood centers with WASH services. So when I talk about WASH, I talk about water supply, sanitation facilities, and promotion of hygiene. So I'll start with hygiene promotion, since I'm a hygiene behavior change specialist. So during promotion of hygiene intervention in schools, amongst the behaviors that we promote is the hand washing with soap. So this one is contextual specific, and in schools we target hand washing after cleaning school environment, before eating, and after using the toilet. So on hand washing with soap, we promote group hand washing, and it's supervised. Group hand washing with soap during break time. And with this we do, since we know that there is a teacher behind it. So I feel like if we are talking about oral health, then it means we also have to include oral health in the hygiene promotion. And that one has to be supervised as well. It has to be a group activity. And this one would be okay because we are already implementing the group hand washing. So it won't be difficult if we included the oral health. Secondly, the water supply. WaterAid provides clean water in schools. Why do we do that? Because we want to create an enabling environment for hygiene practices, good hygiene practices. So you cannot brush your teeth without clean water. If you use dirty water, it means you are creating a complex. It's like you are adding more problems to the young ones, but you have to use clean water for brushing teeth. So I feel like the inclusion of oral health in water supply, that is key as well. So, and then the other one will be provision of sanitation facilities. WaterAid provides menstrual hygiene management facilities It provides hand washing with soap, facilities. It also provides toilets for learners. So you know that if you want to brush your teeth, you have to use sink. Without that, then everybody will just be brushing teeth anyhow, and that's creating a very unhygienic environment. So provision of sanitation facilities would be key in the oral health as well. Then we are also talking about system strengthening. Why do we focus on system strengthening? Because if you want to sustain good hygiene behaviors, you need to have a functional system in schools. And so we work with school management committees. We work with parents and teachers associations of Malawi, of schools. We also work with Ministry of Education on management of infrastructure. We train them on in operation and maintenance of the facilities that we have provided. And we also mentor them on how they can do resource mobilization. That is for sustaining the good behaviors. So I would say that oral health and WASH, they're just compatible. We cannot run away from that. The best is just to integrate oral health in WASH, and we are good to go. Thank you so much. I think for now, I have to stop there. Thank you so much, Professor Bragg.
Thanks, Maria. It's like a tag team of promoting WASH here. So, I mean, I think as anyone who ever talks to me about anything knows that I think water, sanitation and hygiene are the golden thread. I fight with my energy colleagues about energy being the golden thread that runs and integrates and puts everything through. I think it's come up again and again today, prevention is better than cure. That's the motto of environmental health as a profession as well. So naturally, you know, oral health and environmental health go hand in hand anyway. And it's great to see the progress in terms of policies and strategies, but I think as many of us know, working in Malawi, those only take us so far, and the hard work really starts once those are in place, trying to get them the actual change on the ground. As Lorna mentioned, just saying something to people doesn't lead to change no matter where you are in the world, and really moving beyond that policy and things into those sustained hygiene behaviours, whether that's hand washing with soap, as Maria mentioned, or whether it's oral health is really the hardest element that we need to move. And a lot of the work that we've been doing in WASH over the last 25 years in Malawi has been targeting how do we move to sustained hygiene behaviours that don't just rely on the infrastructure, which we know we need, and the consumables, whether that's the toothpaste or the soap, but also to the actual desire to do that practice and get that into sustained behaviours. So just to mention a couple of up-and-coming opportunities that Jeremy and I have been exploring and discussing happily on trains back and forth between Edinburgh and Glasgow. So we've got currently a colleague at MUBAS that you've heard about earlier at the Washtead Centre, Kondwani Chidzusano, unfortunately couldn't join us today. But Kondwani has a fellowship at the moment with the Reckitt Global Hygiene Initiative. We work in acronyms, don't we? Forget what we stand for. So Kondwani is currently undertaking a fellowship which is focusing on early childhood development centres. It's really building on work that we'd previously done in hygiene around hand washing with soap and feeding in those centres, and work that Maria mentioned as well that WaterAid have also done in the national guidelines. And taking those guidelines into practice, what can be used in terms of contextually appropriate, affordable and suitable mechanisms for getting good hygiene into these. And I think this is a perfect opportunity for us to look at how we can integrate oral hygiene practices into those as well as we go through that in the next couple of years. And maybe secondly, something that we've also been discussing is we have an NIHR Global Health Research Group at the moment that looks at early adolescence and particularly health and well-being around early adolescence. It has, again, a focus on a number of different areas, but particularly on water, sanitation and hygiene. And again, integration at that older age, although not necessarily the initial target, but that older age of 10 to 14 could be a real opportunity to look at how we integrate that as well. So I'll just stop there.
Well, thanks to the trio for bringing us up to date too on these opportunities. and the extensive collaborations that are already in place. Now it's your turn. We're running a little late. I have heard from Tash that there aren't very many questions in the chat box yet. I don't know who's going to supply me with the questions if they are there, or take over from me to do this.
I can assist you if there are any.
If there are. So at the moment, it's up to you here. I'd like some comments on these most inspiring talks, examples of really interactive working. Barry.
Thank you, Heather. Just over 5 years ago, I first met Jeremy Bagg thank you, sorry. Barry Clarkson, emergency medicine doctor from Dundee, and the lead of the Scottish Emergency Medicine Malawi project. Just over 5 years ago in this very building, I first met Jeremy Bagg, and he told me of his, and he told us all actually at this very health forum, of his aspirations and his ambitions for a dental school in Malawi. But I think today we've heard that that's gone beyond that. It's the collaboration, the synergy, the successful project led by Malawian priorities, which is what we're all about in the Scotland-Malawi partnership, is an exemplar for us all. And I think it's to be commended. And these two young people, the products in only that short space of time, were going on and will no doubt be the future leaders of dental health and oral health in Malawi. It's just amazing to hear from you. So thank you for coming the long journey and sharing that with us. Mapatsa mentioned that the synergies with all the other specialties for, very, very importantly, subspecialist training in oral health in Malawi. He missed one, emergency medicine. You know, there is another disease process and pathophysiology that goes on globally, but in sub-Saharan Africa at a higher rate than it does in the global north, is trauma-based problems. And we know that the inexorable rise of trauma-related problems. So I noted, we talked about maxillofacial surgeons, and that's going to be something for the future, obviously. But you've got to link there because the exemplar of emergency care in Malawi is in Queen Elizabeth Central Hospital at the Adult Emergency and Trauma Centre there. And I'm sure those colleagues would be willing to form synergies and link with you. And when we get our funding back and we're back delivering what we started with the other 3 central hospitals in Lilongwe, Mzuzu and Zomba, there'll be an emergency and trauma centre at each of those, which will be a national network of emergency care. So look forward to another future synergy. Thank you.
Thank you, Barry. Indeed, I think, as I've alluded to too, there are so many similarities between different areas. And likewise, I met Jeremy, first of all, when we were talking about HPV in the oral environment, as opposed to the cervical environment where I was working. And somehow we need to break out of silos that have happened for decades right across healthcare. And I think we're trying to do that. I think these are all examples where actually we need to think out of the box, look further to the sort of usual contacts that we've had in the past, and see that there are links between specialties that at first we thought there was no connection to.
I think Dr. Machenga has his hand up there.
Okay, wonderful. Dr. Machenga, please do come in with your question or comment.
Yes, thank you very much for a very enlightening discussion. I wanted to comment on Professor McPherson's presentation as well as that of Don, and that up to over 3,000 children had no feelings in them. This suggests that obviously the access to oral and dental care is not available. And so one way in which this can be addressed is the use of that mobile dental clinic. Because at the moment, the idea is that dental teams comprising of a dentist, a dental therapist, and dental students can go out into those schools and offer oral and dental services. And they should be able to do the fillings that we are talking about. And in such a way that next time we have a survey like that, we shouldn't find that among the over 3,000 children have got no fillings where they needed them. And I actually, so this collaboration is very, very important as far as I'm concerned. And the dental students that we have at the moment and those that will come are key in terms of rendering these oral health services, even these prevention procedures, prevention initiatives. So this the establishment of the dental school by the Malden project is something that is really top of the class and should be encouraged. And I hope that we will work together as different partners, each one contributing our own special areas and specialist areas to making sure that Malawi has got a better oral and dental health service. Thank you.
Thank you, Dr. Machenga. Lorna, would you like to say anything in
response? I agree with what you're saying, James, there, that there was a big issue and it surprised us. We found absolutely no fillings at all, which, as you're saying, just showed that, the issue that we have at the moment. And I think it probably needs to be addressed in a number of different ways. As I say, there is a problem with the workforce, there's problems with the surgery availability, and outreach would be one potential part of the solution. I know that Jeremy's also working on trying to develop more sort of primary care centres that would also be available for treatment as well. So it's quite a big piece of work that's going to be required. Yeah, and again, finance is a major issue.
Thank you. I see that Ruthie Marcus has her hand up. Ruthie, would you like to unmute and... Thank you. Yeah, no, I think you're still muted. still muted.
I think she's muted.
Yeah.
Sorry, I'm just trying to find my unmute in my panic. Good afternoon from Malawi, and thank you. First of all, thank you all very, very much for what was a really fascinating presentation. I was going to ask actually Dr. Machenga, James, wait, hang on, I'm blind as a bat. James, who just spoke, Dr. James Machenga, I would concur with his thoughts vis-a-vis mobile health centres sort of going out. But does he concur that, our thoughts very, very much, hence the emerging project that Jeremy is aware of at Chilamoni to create at least, one exemplar dental clinic at healthcare level, that possibly the long-term future comes in the development of such dental clinics at primary health level, such that we don't see the enormous referral of patients to, or where I am, Queens and the like. That was sort of question part A. And part B, Dr. Machenga will know as well as I do that the sustainability of consumables and drugs at health centre level is quite difficult. And, it would be really, really nice sort of over the long term if we could get some joined up thinking on this so that there's a sort of holistic approach to it. Does that make sense?
Absolutely. I see some nodding.
Yes, indeed. It makes a lot of sense. It is very true. I am familiar with the developments at Chilamoni, as well as there is another, Jeremy would actually agree with me, there's another group that wants to start another clinic like that in Nkota. And so at the moment, there may be isolated places like those ones, but eventually that is the way to go so that the health centers can receive this kind of thing. The other thing is that the personnel to do this has been lacking. We have not had that, especially at the graduate level. And so that is why I am at the moment emphasizing that the students should be able to take this through, but it may be done in phases so that, for instance, when the bus comes, we're thinking of going to the clinics which are available, like for instance, at Lisungwi. There's a good dental clinic there, and it could be a good center where the students can also learn. In other words, these can also be learning facilities for our students, an extended teaching platform type of thing. And so in that regard, we will make sure that we use every available opportunity that we have. Notwithstanding the cost of dental materials, it is quite prohibitive. So obviously, Lorna and John must make sure that the prevention takes place before we need to do that. But I was wondering whether SMP now can actually try to focus in this particular area so that the dental materials are available. This is consumables, and maybe put some extra effort in that regard and touch dental caries while it's still small. Thank you.
I'm very sorry, James. We have to disillusion you about where SMP has funds. We won't be able to help you in that particular way, but support for the networking is a different issue. And I'm going to hand over to Jeremy to respond, and then to Patso after that. I knew once we got started chatting, you'd want to carry on. So Jeremy first.
Just very briefly to acknowledge the tremendous support that Ruthie, through her charity Amica, is giving to the project at Chilomoni. So the capital work started this week, and the Amica are funding £15,000 worth of construction work for the dental clinic alone. But what Ruthie's charity is doing is also upgrading maternity and physiotherapy. And we just saw pictures yesterday of the first young child with cerebral palsy in the new physiotherapy clinic. And it's just tremendous. And just a little plug for Scotland Malawi Partnership and all you do. Ruthie and I know each other because it was a result of your newsletter where our blog was mentioned that Ruthie knew how to get in touch with me. So thank you.
Networking is at the crux of it all. Patso, would you like to come in now?
Yeah, now speaking as somebody who had been a principal of a college and also looking at where I'm going, I think the issue of sustainability from day one, that's one of the things that I was told that it's an expensive thing. But there are ways how you can go through it. Yes, we want to go to donors, but how do we as Malawians own that? Because that's the only way we can sustain it. So like the design of our dental school, we deliberately put in a private wing because we know that there are people that are on medical schemes. They can pay for that, and it helps to pay for those that are not able to afford. Can we start thinking like when we go, because my worry is the students as they graduate, we need to send them to the districts. But if the district don't have the consumables, how can we think out of the box to make sure that the district where we would have the exemplary clinics have the supply to keep the students there? So maybe in terms of HEF financing, out of the box thinking will be something that we might want to discuss as we go forward. And also the thing that Jeremy had talked about with in terms of having cheaper but very good fluoride toothpaste. I think it's something that we can manufacture in Malawi, and I think it's something that we need to do, because if I go to my village, you tell the people to wash, but they can't afford that, then we haven't achieved anything. Thank you.
Thank you so much for those comments. Now, are there any others as we, Stuart? Yes, we're approaching 12:30.
Hello, I'm Stuart from the staff group of the Scotland Malawi Partnership. Just building on Dr. Mapando's point there about the availability of consumables in districts. We heard both from Chifundo and Esther about their plans to work in academia and restorative dentistry and to continue to support Malawi as a nation. We all know that it's an absolutely fabulous country and place to be. What other factors are required to retain Malawian graduate dentists in Malawi?
It's a very good question for you two especially.
I'll just talk about what I think is required. Currently, I would say maybe a postgraduate degree or any qualifications that would be because most of us would actually like to go further with education, but currently we can't do that in the country. So that would actually make us go out of the country. Thank you.
Yeah. Would any of the academics online like to say how they think
To me,
and keep your graduates?
Mwapata back again. I did a bit of work with colleagues, though it was for the medics, and also did some work with African Network. In South Africa, it has been shown, you know, if the environment, over and above the salaries, if the environment is good for practice, that will retain people. And if we have also sometimes targeted recruitment for people that are coming from where the needs are, in South Africa, in Umtata, it has shown that eventually, even though they go for postgraduate, they return to help their community. So to me, those two, I think they can also work in Malawi, because you don't want to be a second-class citizen somewhere else. But if you are in Malawi, you have a good environment, I think that can help.
Thank you.
Yes.
Yes.
In addition, sorry, I'm just starting in there, but in addition to that, I want to agree with the fact that the environment should be such that the dentist would stay there. One of the things that we have done is to make sure that these are trained people. And therefore, the facilities that we have, like the example at Jeromoni, if that facility is duplicated elsewhere, and obviously the materials and everything is available for them, for their use, they will most likely stay, because they will be doing what they like to do, what they have been trained to do, and they will not be frustrated in that perspective. Another aspect is to have some continuous professional development type of thing, support for them, so that there is an ongoing learning processes where they will not feel that they are left out alone and then abandoned in that kind of sense. So I would encourage, therefore, to strengthen the Dental Association of Malawi, so that these people know that they belong to an association, and then they can get support from them. And with the support of the university behind them, I think that somebody who will most likely stay, and they will be happy. Thank you.
Thank you, James. Can I just add, as a very white-haired, long-retired healthcare professional, that CPD, that experiential learning, is what should keep you practicing before thinking perhaps another degree is the essential thing that you need next. And I hope that you can indeed be retained in practice, because Malawi needs you at that level as well as in academia. Unless there are any other burning questions. Oh, someone else. Oh, Ruthie.
Ruth has her hand again.
Yes. Okay. I think we need, Ruthie, if you can unmute yourself, if you...
Unmuted. Yes, I cannot actually reiterate more what yourself and James have just said. I think that the support for the emerging graduates is absolutely and totally and utterly vital in terms of retention. But of course, it's chicken and egg. We need the facilities in order to retain everyone. So I just wanted to reiterate that. I also just wanted to congratulate the 2 participating students. I think they're absolutely amazing. Amicus is an organisation, some of you may be aware, that we sponsor quite a few students at QHES. QHES, oh, I always want to call it College of Medicine, but anyway. Yeah. Yeah, I think that we ought to be mindful that these students have succeeded in spite of, not because of. Their achievements are really unbelievably amazing. Their challenges as students, financial, every which way, cannot be, underestimated. And I think a hearty congratulations should go not just to the 2 participating students in the UK, but to the whole of their cohort, and getting as far as they did, because let me tell you, they have serious, serious problems. So many congratulations to them.
Thank you very much. And that's perhaps a good point for me to bring the discussion to a close. I've been amazed and humbled by what has been achieved and the potential for the future. When Dr. Makiwa talked about the long journey to reach this stage, then the contrast with the speed at what has happened in the last 5 to 6 years is quite amazing. But the other thing that has amazed me is how many overlaps there have been as you've presented, whether it's CPD, whether it's mobile clinics, whether it's lack of resources at the district level, and whether DHOs can supply what should be essential resources and consumables. Thank you all so much. Zikomo Kwambiri, to all our presenters, both here in the room and online, for what have been really interesting, engaging and encouraging discussions. Thank you for the time and effort of your presentations, your questions and input to this discussion. And as Ruthie has said, a special thank you to the student presenters. I found it very interesting to hear too about your career aspirations. You've been inspiring, and I'm sure you will be in the years to come. But I now officially close this Health Forum meeting, say farewell to our online attendees, and hand over to Chad just to finish off.
Is it?
I think so. Thank you all very much indeed. I hope you've enjoyed it.
Thank you.
Yeah, thank you for joining us online, and thank you all for the many presentations, and for particularly for Jeremy for actually pulling it all together, reaching out to all these colleagues. So thank you for joining us online, and thank you, Heather, for chairing the meeting. And we hope to see you all soon, either here or in Malawi. And those of you who are here, please stick around for another cup of coffee in Malawi, coffee or tea. So thank you very much.
Thank you.
Thank you. Bye-bye. Yeah. Well.